much. Let me invite my dear colleague and friend Chee from Singapore. She's going to take us through the one of the difficult areas. Chee, all yours.
Okay, thank you so much for inviting me to participate in this wonderful course. So I've been asked to talk about subluxated cataract. Let me just quickly go to this. This is a manual approach. I've also been asked to address the femto approach. So the strategies in dealing with the subluxated cataract, we need to deal with vitreous, and you can see that. We do that as a first step so that we do not endanger the posterior segment, the retina. So we're dealing with it and from a past plane approach, because this is a really posterior subluxation. As you can see, the lens is dropping back because the vitreous that is supporting it has been removed. And that can be done with the help of triamcinolone acetonide so that we're sure that it's actually completely removed. And we are using a 27 gauge needle to bring this anteriorly. And I'm grasping it with non-tooth forceps. And I have all my paracentesis and my capsular hooks ready so that when I brought it to the anatomical position, I'm ready to hook it up. And once the first hook goes in to support not just the rim but the equator of the bag, it's now easy for me to continue the capsulorhexis, as the hook also provides the counterforce for tearing. And in an area where I don't have counterforce, I can use my non-tooth microforceps as well. Right, so this is now easy to tear. I then insert the hooks one after the other to provide the adequate support to do phacoemulsification. Okay, so what do we then do next? After supporting this hook, you know that there is very little zonial integrity now. So the next thing to do is to protect the equator of the bag, which will still come between the hooks because it's not supported. And so the important step is to dissect the area just subcapsularly so that there's space for the CTR to be inserted without trapping the cortex. Now I'm just doing a little troughing here. This cataract is not very difficult. And then after that, I insert the IOL into the capsular bag. And this is a stage where we put in the CTR, the CTS now. We need two supports because there are hardly any zonules. And after pulling these sutures out from the Hoffman pocket, we do a 2-1-1 knot, but we don't finalize the tension until we have actually ensured that this IOL is centered, and I actually take out viscoelastic first, and then very important that this Hoffman pocket is deep enough so that the knot is well buried. And you can see this is the EDOF lens, and how did this patient do? You can see the refractive outcome, and you can see also the centration of the IOL. This patient did very well. Okay, so we go on to femto cataract. This is advantageous, especially in lenses that are not so posteriorly dislocated. It creates a centered, well-sized capsulotomy, and no countertractions needed during the capsulorhexis stage, regardless of the anterior chamber shallowness, whether there's vitreous or not in the anterior chamber, whether the lens is slightly descented, we can still do a capsulotomy in a jiffy. Nucleus fragmentation really helps because it enables phaco, especially when the cataract is dense, and also reduces the need for nuclear rotation as you can tumble the pieces that are pre-cut out. So let's have a look at this patient who's an adult. When he found out he actually had lens dislocations and was subsequently diagnosed with Marfan syndrome. And you can see we're decentering it, and this is actually on the scanned capsular bag. I can decrease the size. All right, I generally like it a little smaller so that it's easier to place the hooks more ergonomically on the rim of the rhexis. So you can see here on the table, first thing to do is to make sure that I don't get vitreous coming forward, so I inject dispersive viscoelastic to fill up the gap that's actually present between the zonules and the rest of the eye. And very important step after removing the capsulotomy, I place my hook and dissect the plane of viscoelastic just under the anterior capsule. And you can see that this needs to be done 360 degrees around, and you can insert that CTR into that clean plane. All right, you can see it skirting around, and that's not trapping cortex. All right, you can do some gentle hydrodissection. Sometimes you don't need it because you got viscoelastic there already. That's dissected off the anterior cortex. And then this is, without rotating, you can just tumble the pieces out using the chopper, all right, to just bring it forward. And you can see that this piece comes out very easily because it's already pre-chopped. In this case, again, just bringing it forward Okay, now this is completely loose. You can rotate it safely without embarrassing any of the zonules that are still remaining. And you'll see that when I remove the cortex, some may be trapped, but usually very little trap is if you're very meticulous in the plane in which you dissect it. And you can see here, really no trapped cortex. Right, so it's not difficult, and it's important to put the CTR in early in these cases of very severe subluxation. All right, because that actually pushes the equator out and keeps the lens in the anatomical position. In this case, I'm doing a toric lens, and also I'm putting in the hooks that are on either side because of severe zonulitis, and Marfan's is a progressive disease, so you need to plan ahead for the patient. You want to anchor both sides so that in time to come, even when the zonules do get more stretched, they do not actually result in lens decentration or dislocation. So that's Hoffman pocket that has been created already, at least half scleral thickness, all right, diametrically opposite sides. We're just putting in a 27 gauge needle that has been loaded with a cortex suture. Use that as a lasso. You could also use microforceps to retrieve it through a sclerostomy, 2 mm posterior to the limbus. I'm just retrieving the sutures there, and you do it for the other side there. And then once you've got them both retrieved, you then tie the 211 knots, but you don't finalize the knot until you're sure that your RL is well centered. Now, if you have an RL that's not well centered, you could actually move the CTS along the equator of the lens to ensure that that lens is well positioned. So you can see that this patient did very well post-operatively. Now I'm going to move on to hard cataract. Okay, so you can see the very, very dense cataract. The first thing to do is remove a bit of viscoelastic from the front chamber so you have some space to work in. Otherwise, you will have a burn very easily at the wound. Your CCC needs to be adequate size, but I generally would still stick to 5 mm capsulorhexis. Very important to preserve the endothelium, so you want to make sure that from time to time you're topping up dispersive viscoelastic. And what you're seeing here is that I like horizontal chops. I know Suvan does vertical chops. I find that this reduces the need to increase the vacuum, all right, because I'm basically crushing the hard nucleus between the two instruments, and this means I need less energy. I also need less vacuum, all right. But what is important is that when we start doing the chopping, you need to be deep enough, right, after having done that little short trench, that you can hold the heart of the nucleus, so that when you do your cracks, it actually goes right down to the posterior plate. And then the next action is lateral separation. Okay, now I have to move on to the next, and we'll talk about femto. This is really quite advantageous for these hard cataracts. It creates the appropriately sized capsulotomy. You can do 5.2 mm capsulotomy for these cases. Nuclear fragmentation really reduces the total phaco time, EPT, CDE, reduced endothelial cell loss, and nucleus disassembly is less effort required. But what's very important is always the plane in which you do phaco and topping up dispersive viscoelastic to preserve the endothelium. So again, here you can make a larger capsulotomy, or you can just do a standard one. I generally still prefer a 5 mm. And you can see here after the femto capsulotomy and segmentation, I don't like to really do too much of a gridding of the nucleus, because I find that it's too much distension of the capsular bag with the gas that's produced during the femto treatment. I like to do 8 segments, but really with the maximum energy, a single pass. And you can see actually it does create a very good cut right down to the posterior plate. So you still need to do lateral separation, all right? You don't really need to do the chop. And once you've separated it completely right down to the apex, you can tumble out the first piece, and you need to keep your phaco actually deep, all right, your needle deep, so that you are away from the cornea endothelium. And as mentioned, from time to time, you need to actually top up the dispersive viscoelastic. So in this case here, you can see we don't struggle that much with the thick nucleus, because in Chinese, our nucleus can be like 6 to 6.5 mm thick, and it can be very difficult to really do that crack and to get it right down to the posterior plate. And you can see that this has been cut very, very cleanly, so we do have a very efficient phaco technique with the femto. So in summary, both subluxated and hard cataracts are more easily and safely dealt with flex than conventional phaco, but certainly it can be done with conventional methods. Thank you.
Thank you, Professor Chee. Wonderful videos as usual and classical teaching videos. Very difficult to handle these cases, no, subluxated, and she does so beautifully, so fast.